I've got two of our faculty from earlier sessions still awake with me and pushing strong. And so I want to bring Turner Vosseller up to the stage as the moderator for this session. And, infections are a real thing, and getting to understand how we're going to deal with it. Turner and his panelists will shed some light on this. So Turner, take it away.
Thanks so much. So we're going to spend some time talking about an outcome we hope we never get. So I've got a really great panel coming, so I'll kind of set the stage and talk briefly about just diagnosis and arthroplasty infection. And then Bonnie Chien, one of our moderators from earlier, will come back and tell us how to optimize our patients preoperatively so that we can mitigate our risk. And then finally, we'll have Eddie Haupt will talk about kind of intraoperative factors and a little bit about outcomes, at least what data we have. All right, let's go. So as I said, I'll talk briefly about just the evolution of diagnosis with total ankle infection. Disclosures remain the same as before. So we'll just spend a little time talking about some brief definitions, and then essentially we'll just go briefly over the evolution of how we've come to think about infection with respect to diagnosis. And so here we go. So infection can be defined in some different ways. So exogenous is basically just at the time of surgery, or if it comes from inside out or outside in. And hematogenous is more the kind of rare kind of late infection, so from transient bacteremia. Timing of infection is defined in different ways. So some people delineate acute from chronic at 4 weeks. The international criteria, as we'll go over briefly, use 90 days. Certainly, if you're talking about things from a surgical standpoint, then it's going to be, acute is really going to be more acute if you're trying to preserve your implant. If you go back to where we started, so not that long ago, 1991, 33 years ago, this was one of the earlier papers I could just find that's a review paper on infected total joint arthroplasty. So back in 1991, we were using the SED rate, which, as we'll go over soon, we still use, although SED rate's probably reasonably sensitive for infection, although meaning if it's low, it probably don't have an infection, but certainly not specific at all. An Indium scan, I don't think I've ever ordered as an attending, not really used much anymore. And certainly we still use aspiration for culture and sensitivity. If we fast forward about 23 years, and certainly there are multiple series on infection in total ankle replacement, but this is one of the earlier ones that I could find that had a reasonable number of patients. And this is from a number of kind of luminaries from Europe published this, but their criteria infection, which will be largely mimicked in the international criteria, show basically the growth of the same organism from two cultures, just from around the implant, when there's visible pus, a sinus tract, or acute inflammation on pathology, which they defined as greater than 5 neutrophils per high power field. So if we get to that international consensus group on periprosthetic joint infection criteria that I've been kind of alluding to, essentially they're broken down between major and minor. If either of the major criteria are present, then it's deemed infected. And once again, that's 2 positive cultures of the same organism or a sinus tract. Or if you have 3 of the 5 minor criteria, which are elevated CRP and SED rate, elevated synovial fluid white blood cells, or positive leukoesterase, elevated synovial fluid neutrophil percentage, or positive histology, or a single positive culture. Minor criteria, they break down based on acute and chronic, and you can see the numbers here. Some have argued for lower cutoff values, especially for the synovial white blood cell and neutrophil percentage, arguing that infection's a devastating complication, and they didn't want to miss any infection. That's basically just where you want to have your error here. I mean, if you want to cut out the false negatives, then you can make these numbers lower, certainly, although that may increase your false positive. But these are the basic criteria that exist currently. So that's kind of where we've been. So where are we going? Well, biomarkers are really what have become more used more frequently over the last 10 years or so. And all biomarkers are, they're basically often peptides or various things that are increased in the setting of infection. So ideally, if you're going to use these to diagnose infection, you'd want something that's accurate and easy to identify, that is not prohibitive from a time standpoint or from a cost standpoint. And so what have we looked at? So this is a study actually from Dr. Parekh's institution, where they went a systematic review and meta-analysis where they went back and looked at a bunch of these biomarkers for prosthetic joint infection, looking specifically at the sensitivity, specificity, the DOR, or the diagnostic odds ratio, and the area under the curve. There's a diagnostic odds ratio is one of the better tests for just how good a test is. And generally, tests that have very few false results have a very high diagnostic odds ratio. So alpha defensin generally performed the best of all of those, with its diagnostic odds ratio was 6.7, which is pretty good. And you can see all the other numbers were pretty high there as well. And they looked at a number of these biomarkers here. Leukocyte esterase, IL-6, and IL-8 were also performed reasonably well, but their sensitivity was just a bit lower. The one thing that they didn't look at that closely here was synovial CRP, which has also been found in conjunction with alpha defensin to be actually perhaps increase even the sensitivity and specificity of alpha defensin alone. So has this been used in the setting of a total ankle? Well, the only published study I could find was out of Hamburg in Germany, published in the podiatry literature a couple of years ago, and just basically a case series where they used the international criteria to define infection and then looked at the sensitivity, specificity, and accuracy of alpha defensin. And as you can see, it performed pretty well in that setting. So those are some of the newer things, and probably the vanguard, I guess, if you will, of diagnosis for infection is the molecular diagnosis of infection. So using PCR, polymerase chain reaction, to assess for bacterial DNA. And there's certainly a lot of detail that can go into that, but it's an extremely sensitive test, and we can pick up strands of bacterial DNA, and it has the added advantages, if we go back to that previous slide, that it's accurate and quick. And you can control for contaminants, also potentially quantify the amount of bacteria. So oftentimes when we get a new test that changes the game a little bit, one thing that we have to understand is the context. And so, because certainly we don't know the relevance necessarily of bacterial strands within a joint. And so some authors have looked at just the ankle microbiome. So, in a normal ankle or one that is clearly not infected, are there bacterial DNA there, or are there bacteria there? And it does seem that there are. And so there's probably still some work to be done to kind of fine tune this so we can make sure we're just being accurate in terms of identifying pathogens. But certainly a lot of promise there. And the PCR is really just tip of the iceberg. There's certainly work that can be done beyond that to refine what data you get from it. So all of that is good, but practically, what do we do? I mean, the thing that certainly, probably needs to be said in this setting is that there are certain patients where everything I just said is really not going to be all that relevant, because they're going to come in and they have pus pouring out of their ankle, and you don't probably need to be a doctor to understand that that's infected. So the clinical exam obviously is of paramount importance, as is evidenced to some degree in the criteria. Oftentimes, obviously, we'll check the serum markers, CBC and sed rate. Aspiration is certainly warranted, although someone comes in with an ankle looking like this, I don't know that that's necessary. That person does have a total ankle under all that mess. But aspiration to look at the white cell count, the neutrophil percentage, you can get the leukocyte esterase fairly easily, and alpha defensin is pretty readily available these days as well. So just once again, to briefly summarize things, it's evolving, although the international consensus group really kind of rule the roost still. I mean, that's what's probably most important. Biomarkers and molecular diagnostics are increasingly prevalent, although maybe a little bit of work to do still with the molecular diagnostics. So with that preface, thank you. I will stop sharing my screen, hopefully more successfully than I started sharing my screen. And now we get to hear from Bonnie. So Bonnie is originally from Taipei, Taiwan, and has been to like basically all the best institutions. So she went to med school at Stanford and did her orthopedic residency at Harvard, and then did her foot and ankle training down at Mercy with several leaders in foot and ankle, and has held numerous leadership roles since she's been in practice, including being the associate residency program director for Columbia University in New York City. She also enjoys global exchange and has been to several places, including Malawi, Colombia, and India, to both teach and perform surgery. So without further ado, take it from there, Bonnie.
So I'm going to talk a little bit about optimizing preoperative patient factors, specifically in the setting of trying to lower the risk of periprosthetic total ankle infection. No disclosures from me related to this talk. And the only thing I'll say is, in terms of optimizing patients, this is specifically focused on infection as a complication. So periprosthetic joint infection, I'll abbreviate as PJI going forward. The rates, at least for total ankle replacement, range, and it's somewhere in the 3 to 5%. As Turner mentioned, a lot of this can be related to either hematogenous, or actually the majority of which is what's called exogenous, or related to the wound. And most of the bacteria that is involved is Staph aureus, and the second most common is coag-negative staph. I'm going to review some of the literature as well, demonstrating what we know, but a lot of what we don't know in terms of the individual factors, as well as a conglomerate and composite of factors that may increase infection risk. And from this same paper that I just mentioned, reporting the rates of infection, some of the other factors that they have identified include prior surgery at the site of infection, surgical time, 2 hours versus 1.5 hours, and persistent wound drainage post-op as some of the factors that predispose to higher PJI infection risk. And I'm going to break it down now and look at some specific factors and the literature around these factors. So first of all, smoking as a risk. So there's one study, had a pretty large sample, and they divided the patient groups into active smokers as well as former and non-smokers. And what they found was that active smokers did have a statistically significant increased risk of wound breakdown. However, they actually did not have a significantly increased rate of infection or needing surgery for an infection or other reasons otherwise. What they also found was that the outcome scores for active smokers was not as good as those who weren't smoking at their final follow-up. And this table is just to summarize again, between non-smokers and active smokers, the really only difference that this study found was that there was a higher risk of wound breakdown, but again, not necessarily meaning these patients needed to undergo surgery or really being formally diagnosed with a PJI. Now, what about diabetes? Large sample of 1,800 plus patients in this study. And what they found was that in the diabetic group, there was a higher rate of infection. And this is in contrast to many other factors that we might think of as being associated with higher risk of PJI, such as smoking, which, as I informed you earlier, maybe doesn't necessarily increase the rate of PJI, but also with BMI in terms of perhaps higher obesity, patients having a higher risk of PJI as well. And I just wanted to include this because I found this when I was doing a literature search, something we see as having growing awareness on our end of affecting patient outcomes. But even for total ankle replacements, one study looked at depression, and they looked at the contribution of depression to a specific time frame, 3 months, and whether or not this affected the complication rates after total ankle replacement. The study also controlled for other patient demographic and comorbidities. And what they found, in some ways, even at a higher rate than some of the other factors like smoking or diabetes that I mentioned before, is that patients with depression actually had a higher rate of PJI, wound complications, and surgical site problems, higher odds ratios as demonstrated here. So I think just something to keep in mind, not a factor in patients that we often talk about or has been published extensively in the literature, but I think, again, something to consider. Then moving on to multiple risk factors. So some studies that have looked at risk factors and treatment options and taking them all together. And really, I would say the findings are sort of all over the place, because this particular study found that risk factors for infection included diabetes, which, as I said earlier, may or may not really be a big factor. Prior ankle surgery, wound healing problems, again, being another factor, especially if you still have wound healing problems more than 2 weeks post-op. However, they did not find any significant difference with respect to smoking, BMI, or operative time. Other studies have looked at database analyses, and what they have found is that, again, all over the place, because now that we're introducing more factors such as age, younger than 65, BMI, but interestingly, even patients with very low BMI, and this may be related to poor nutritional status and perhaps more compromised immune system to combat and prevent PJIs. Again, they found multiple other factors that may contribute to PJI, some of which we talked about as being a little bit controversial: smoking, diabetes, and again, introducing other factors such as peripheral vascular disease. Even more database analysis. Again, more the purpose of showing these slides is that there's conflicting evidence regarding a lot of these factors. And some of the traditional factors that we may consider, such as obesity, smoking, and diabetes, are not absolute in terms of increasing the risk of PJI. The AOFAS did come out with a recommendation that they posted in FAI. And again, this is all maybes in terms of factors that predispose to PJI: inflammatory arthritis, prior ankle surgery, BMI, in some ways counterintuitively, but it makes sense, being on the lower end, under 19, and then peripheral vascular disease. What about some things that are not necessarily patient-specific factors, but as surgeons, we may offer to these patients preoperatively before they undergo surgery? So steroid injections, there really is no definitive data on the ideal timing. We kind of follow what has already been published in other total joint replacement literature, such as in the shoulder or hip and knee, and that we recommend at least 3 months between a corticosteroid injection and especially if you're considering performing a total ankle replacement as opposed to a fusion. Preoperative optimization factors in the immediate perioperative period, again, similar to our hip and knee arthroplasty colleagues. I'm not going to read through all of the different strategies that you may employ, but this paper is available, and I try to include all of the different citations as well as the PMID for your reference. So you may look up these papers as well. What I wanted to share in particular was something that, again, is borrowed from the hip and knee literature, and what they published on was something called the Mayo Periprosthetic Joint Infection Risk Score, which really looks at baseline risk factors, some familiar players we've seen before: BMI, previous surgery, immunosuppression, operative time, and taking a composite of these risk factors as opposed to looking at them in isolation. And they did some fancy statistics and came up with weighting of these different factors, as you can see on the right of this table. And then the sum of the scores really is what determines your risk of infection. So the higher the score, the higher the risk. This is a paper that I worked on with my fellowship group, and you'll recognize some familiar names such as Dr. Schoen. And we basically apply the Mayo score from the total hip and knee literature to ankle replacements. And what we found in our sample of around 400 total ankle replacements, our rate of infection was about 2.5%, so in line, if not a little bit lower than what has been reported in the literature. And our non-PJI patients had a significantly lower Mayo score, like 2.5, compared to those patients who did develop a PJI, which was about 7, almost 8. And sort of saying this in other words, the odds of PJI increase with your Mayo score. And if you look at the figures demonstrated here, you can see that with the Mayo score increasing, the probability of PJI also increases. And there's this inflection point at about 5. So if you have a score of 5, the probability really jumps. And this Mayo score predicts total ankle PJI similarly to the way it has for the hip and knee PJI literature as well. So again, just to show in a different way how a Mayo score of 5 can be significant in our sample, every one of the PJI patients except for one had a Mayo score that was greater than 5. And we really, in many different ways, demonstrated that this is the cutoff for a higher risk of PJI. Now, if you look specifically at our patients who had a Mayo score that was above 5, we found that there was a higher rate of PJI cases within the sample of patients with a score above 5. So their PJI rate was 12%, whereas for the patients who had a score lower than 5 or equal to 5, it was only 0.3%. So what we took away from our findings was that, and to show here in this table, no specific individual factor really predicted PJI risk in the same way that if we took a composite score as represented by the Mayo score of greater than 5, so no single risk factor predicted PJI. And so hopefully this can be helpful to all of us making a decision about counseling patients, whether they may be a good candidate for a total ankle replacement, or even just optimizing their preoperative factors going into surgery. That if you look at the score as opposed to just the individual weeds of and kind of the really messy weeds out there of the individual factors, that this can help us, I think, better predict PJI risk for total ankle replacement. So again, just to show you again the reference for this paper, and hopefully this is helpful to all of us and something that can be easily applied in the clinical setting to help us provide the best care and optimal outcomes for total ankle replacement. All right, I'm going to stop sharing.
All right, thanks, Bonnie. Great talk. So our next talk is by Eddie Haupt, who's here at the Mayo Clinic in Jacksonville. Eddie couldn't be here tonight, so he recorded his talk. So I'm going to share again, and then we'll get his talk going.
Hello, my name is Eddie Haupt. I'm a foot and ankle orthopedic surgeon at the Mayo Clinic in Jacksonville, Florida. We're going to be talking about intraoperative management of total ankle prosthetic joint infections.
Can you guys hear the volume?
So first about me, I'm a couple hours south of Jacksonville from a place called Merritt Island. It's very close to where the space shuttle lifts off. It's probably the most notable thing is most of the people that work there either work for the space industry or the cruise ship industry. I went to the University of Florida on a football scholarship. We were very successful, won a couple of national championships while I was there. And see which one if you think you can find me in that picture. I stayed there for medical school. I also stayed there for orthopedic surgery residency. Then I ultimately matched into foot and ankle. I ended up having 3 little girls while I was a resident. There's my wife. Obviously very grateful for them. Couldn't do it without them. I matched it for a foot and ankle fellowship at Cedars-Sinai Medical Center in Los Angeles. I had a wonderful year there, and then I've returned to Jacksonville to the Mayo Clinic, where I'm now in practice. Here's my disclosures, none of which are pertinent to this talk. And here's our objectives for today. Now we're going to talk about intraoperative management of prosthetic joint infections, specifically total ankles. We'll talk about intraoperative tips and tricks. Then we'll talk about exchanges of components, spacers in their usage, and long-term outcomes. So I think we've heard a lot about total ankle replacements and prosthetic joint infections. So now it's surgery time. And I think the key things going into this is that whether you have a definitive diagnosis that you know it's infected, you know the organism, or you're highly suspicious, you're almost certainly going to be doing a lot of the same things. And so intraoperatively, once you've reopened the exposure, whether that's an anterior or lateral approach, some of the things you're going to want to do essentially immediately is to obtain your intraoperative samples that you may use to make decisions. And so if the diagnosis still hasn't been made, something that's very helpful are to obtain frozen sections. Here, I think we have a very good pathology department that works very quickly, but nonetheless, from the time I send it off until the time I get the results, at a minimum, it's going to be like 45 minutes. And so you want to get like a synovial biopsy or two. I usually send at least two, and send those off the field for frozen section as fast as you can. You're otherwise going to send cultures. You can consider using next-gen sequencing or PCR techniques, especially if somebody's had antibiotics already. But again, those aren't going to help you during the surgery itself. The only thing that's going to give you any more information to help clarify things are the frozen sections. You're going to safely remove the implants as soon as possible too, especially if you were planning a two-stage revision. But I think as soon as possible always needs to be colored by the fact that you're trying to preserve as much bone as you can. You want to minimize any complications of a future revision. So just like I said, TikTok, get those frozen sections to your pathologist as soon as you can with the synovium. And if you're thinking about doing a DARE, well, that's the only ones you need to get off the field. But otherwise, I would try to constantly continue moving forward to get the metal implants out so you can send frozen sections as well from the underside of the metal implant. So from the bone implant interface, you want to be able to send bone to the pathologist. People have examined this pretty extensively in the hip and knee literature. Sensitivity and specificity of this frozen section is pretty good. It's greater than 90% for both. Consensus groups, when you ask them, 80 to 90% of the consensus groups agree that it's a useful test. So I think pretty much everyone would agree to do that intraoperatively. What are they looking for? Well, they're going to take samples, turn them into frozen sections, do an H&E stain, and look for neutrophils. And when you have a high power field, like for example, the one I'm showing you is a high power field, if you can see more than 5, then that's when you achieve that greater than 90% specificity and sensitivity. So you can see on this slide, there's tons of neutrophils. And so this one would be concerning for acute inflammation. That's what the pathologist will say. Otherwise, everywhere that you do a biopsy or a frozen section, send cultures. So from the underside of the implants, from the synovium, from anywhere else that might be concerning to you. A key factor that seems to be very important in the hip and knee literature nowadays is that there are low virulence organisms that can take weeks to appear in culture. And so if it's not a default in your institution, ask for these cultures to be held for at least 14 days. There's a growing popularity of something called next-gen sequencing or using PCR. The advantage here is that the bacteria don't have to be alive to survive in a bacterial culture. We can just identify sequences of their DNA that might be in the environment. Perhaps they've already been killed by the antibiotics. And so you can identify their presence from DNA amplification. I think the sensitivity specificity of these tests are still unclear. There's been studies recently on this in FAI and elsewhere about the ankle flora. There might be normal bacteria that live there. Some of these tests have been shown to have positive results just when you culture the air. So I think we still don't really know the true usage of these, but if we're in a negative culture situation for a patient, it's a useful test, especially when they've had previous antibiotics. So next, you're going to be deciding on 3 possible pathways. Most of the time, you're already going to have a plan for what you're going to do here, but in the setting of a prosthetic joint infection, there's really 3 ways to go. There's doing what's commonly referred to as a DARE nowadays, which stands for debridement, antibiotics, and internal component retention. That's the same thing as the classical term of a poly swap. So if you're going to leave the metal, so the talus and tibula trays, and you're going to take out the plastic liner and put a new one in after debriding, that's a DARE. Or a poly swap, it's the same thing. I think I bring that up because there are studies that will describe Removal of other metal components, for example, a medial mouse screw or fibular plates as a dare. That's not really a dare, the way the hip and knee literature describe it. So whenever you're scrutinizing the literature, be sure you know exactly what they were referring to as a dare. The key thing about this is that you're going to irrigate, you're going to remove everything that might be contaminated with a synovectomy, almost like a tumor operation style synovectomy. There's a weak evidence about perhaps scrubbing the implants or using a compound called Bactisure or other detergents, which may break up biofilm. I think the literature on that's very weak, but that's a new and interesting area. You'll put a new polyethylene liner in, and then you'll close. As it pertains to actual metal component revisions, the American gold standard is to do a 2-stage revision, which means to actually explant both components, explant the plastic, place an antibiotic cement spacer to maintain your soft tissue tension, and close. That'd be your surgery, and then come back later for your revision. Keep in mind that's not what's done not only everywhere in the United States or in the hip and knee world, but elsewhere in the world. There is a growing popularity of trying to do either what's referred to as a 1.5 stage, or doing even in an infection a full 1-stage revision where you remove everything, perform your debridement, don't put a spacer, and actually put in the new implants. But continue antibiotics and those kind of things the way you otherwise would here for a spacer. And I think there's no data on that in the ankle, and the data in the hip and knee is burgeoning, but it's very interesting, and I think it may become important in the ensuing years. So let's talk about, the dogma favors a 2-stage, but there are certain situations where this dare or polyswap would be an appropriate thing to do. Acute infections are things that might be hematogenously seeded. So you had your bacterium for something else. If you're able to get to this within days, it seems like in the hip and knee literature that raises your degree of success. And but you may still require lifetime oral antibiotic suppression. That's something I think the literature doesn't know after your surgery. There's some other factors that are going to favor a 2-stage. Like if there's a wound dehiscence and the wound is unable to be closed, that usually is going to favor a 2-stage. If you don't know what the cultures are in the hip and knee literature, there's some mixed data about whether that indicates doing a 2-stage, but that's something to think about. And then there are certain specific organisms, MRSA or MRSA being probably the most popularly described, where once it's adherent to the implant or shown to be positive in the cultures, that there's very little chance or success with a dare. We'll talk about that again. So let's just talk about removing the implants real quick. So as it pertains to polyethylene liners, you got to know your system. Some of the systems have extraction devices or other tricks. I would definitely talk to the reps ahead of time, even if it's not the system that you are familiar with. Ask them what the tips and tricks are to get it out. You really want to know how to preserve the locking mechanism of the tibial tray. If you're planning a dare, you got to be able to put a second polyethylene liner in safely and have it actually lock, assuming there is a locking mechanism. And so you want to be able to perform this while minimally damaging the intact components, especially the way the polyethylene liner locks in. Otherwise, you'll have to be revising your tibial tray too. So something to think about is that, beyond the extraction devices and some of the other mechanisms where you pry it out with an osteotome or a freer, you can always destroy the poly, and as long as you're able to protect the metal components at the same time. So you can always drill a Steinman pin into the plastic. You can use osteotomes to actually break it into fragments, or you cut it with a saw, or drill into the segments. Those are all possible options. So of a couple of common implants here, the one on the left actually has like a Steinman pin extraction screw system, although you can pry it loose with an osteotome. The one on the right, you would actually need to drill out the dovetails in the corners to disengage the locking mechanism. You can pry it out with an osteotome. Again, be very careful not to damage the metal. This one here on the top has a mobile bearing. So you can just grab it with a coker and try and pull it out or break it in half. But there is no locking mechanism to mind. And then the implant here on the bottom, actually has a metallic locking clip, and that's going to have to be removed at some point to be able to reinsert a new polyethylene liner. And so you carefully plan, know your system, talk to the reps, and use them to your advantage. But if moving past the dare, if you're going to have to actually revise the metal, again, know your system. Some of them are going to have like something that can actually hook onto the metal piece itself and help you disimpact it. But and also there are devices where if they're 3D printed titanium or a sinter bead setup, you can usually saw through that, which may simplify the extraction through the peg and cage elements. Those can then be more difficult to remove, but getting the actual tray itself out may be easier in that respect. So I think the tools that I usually use are flexible osteotomes, which there's a bunch of different brands of those that I have some pictures here on the top. And I use the smaller SIP blade that I think most of us use here on the bottom right. Key being to always stay right at the metal implant interface and disconnecting that as much as you possibly can. And then, you may have to consider using Trifines or something for a stemmed component if it's out there. Once the bone implant interface is freed up, then you can usually gently pry the implant out using a free or an osteotome key elevator. Excuse me, something like that. So, these two implants we showed before, you just have to get around those pegs using your small saw blade or flexible osteotome and break it up as much as you can, perhaps also around the shoulders of the implant. Once it's totally free, then you'll be able to pry either of them out, being careful that this one they both have these two diagonal pegs in the front. The one on the left is slightly larger diameter pegs, but it also has this little fin. And so you just have to angle around this as you go. You really wouldn't want to skive off the top of the peg and take out a huge chunk of bone if you can avoid it. For here, this implant with its barrels, you would be using a saw, flexible osteotomes to go around the barrels, and then either drilling around the barrels, or something like that to be able to disconnect it. The implant on the bottom, same thing, angling around the pegs as well as the cage, possibly considering cutting through those with a saw or a diamond tipped burr. So moving on to the talus. The talus, some of the newer components are a little bit easier to get access to, but keep in mind most talus components have a curved element to them, or if it's a flat top talus, the pegs themselves may be difficult to actually get to the bone implant interface. You kind of have to angle both around the anterior flange of these components, but also off the medial and lateral sides. The same tools are very helpful, as well as using, the cookers, towel clamps, vice grips, etc., to get it off. You're just generally going to be working all the way around these until it's free enough, and then attempting to pry it off. When to pry it off is a tricky thing, both for the tibia and the talus, because you don't want to attempt prying it too early, because you may rip off a large piece of bone still attached to the implant. But then again, you don't also want to be screwing around with these osteotomes for too long either. So usually for me, after I think I've touched every portion of the bone implant interface, I'll begin to start prying it off and see if I can figure it out. And for the taluses, I think, this implant on the left that I keep showing would be more straightforward because it's a flat cut. You just be angling around the peg and the fin elements. The one on the right, there's chamfers, and so as long as you're able to hopefully get to most of the chamfers from the medial and lateral sides, it'd be more straightforward. I think the implant here on the top would be pretty difficult. It has that kind of helmet appearance where the lateral wing is pretty long, so you'd be doing most of your work from the medial side, and really, honestly hoping that you can get to most of it without having to do a lot of osteotome. Hopefully it'll pry off early in the game. Whereas this implant here on the bottom, you'd be able to get to most of it from the sides and hopefully some from the anterior flange. You really, in a perfect world, wouldn't want to take all the bone off from underneath the anterior flange, because you might be able to preserve some under the chamfer. Will it really matter if you revise to a flat top implant? Maybe, maybe not, but you wouldn't want to cause any cavitary defects if you could otherwise avoid it. So the implants are out, get those other frozen sections off, and then begin your debridement. I would say, this is like a tumor operation where you're going to basically remove everything that may have been touching the area of contamination. So take it down to healthy bone on all sides, which is going to include the inner portions of the malleoli for me. You may also want to think about other areas that were touched by this. Is there a brostrum with fiber wire sutures or some other kind of permanent suture material that needs to be removed? Are there medial malleolar screws? Those are going to need to be removed. And then I would perform the fullest capsulectomy that you can, anterior and posterior. If for a dare you're going to implant your new poly, I think the question of whether you're going to use topical antibiotics, the jury's still out, but I think almost everybody, if it can help, you might as well just do it. Close, however, is going to be the safest for you. There's no answer about whether wound vacs are going to be required, but I think most people would use something like that. There's very limited data in the ankle world. I'm going to show you that in a sec. But in the hip and knee world, you're going to get 6 weeks of antibiotics after this, generally via a PICC line, and definitely get your infectious disease consultant involved. Let's talk about cement spacers real quick. I think we should all remember what we did as residents for in the hip and knee world, or if you still do this. We're on the 3rd generation at least of cementation technique, and so when you're doing a good job of implanting a component, you want to maximize the cement's ability to interdigitate into the bone. So you remove all the debris and cells with pulse lavage. You're going to minimize aeration of the cement. So when you mix it, it'll be in a vacuum mixer. to pressurize it with a pressurization gun and otherwise using cement restrictors. And then you can put antibiotics in the cement. That's controversial, but you want to limit the amount because the more antibiotics that are in there will form holes as they elute, which will contribute to aeration. And so when you're doing a cement spacer, though, don't do any of these. You want to do a bad job. The reason is you're going to be planning to take that cement out soon, right? So the goals you have to accomplish are to hold your soft tissues at the right length. You want to deliver a maximum amount of local antibiotics, and you want to make it easy to remove for stage 2. So yeah, you just make it big. You're going to put it in when it's fairly doughy and make it a big enough gob to fill the space. But beyond that, extra cement that goes in is going to just be harder cement for you to retrieve in round 2 that might be in the back or up inside the talus or the tibia. So be mindful that if there was a huge defect there, you actually don't want to fill the whole defect. At least with cement, it's just going to be harder for you to get out later. We talked about delivering local antibiotics. There's a bunch of controversy about this, but I would essentially say that the more the better, as long as it forms into an actual ball, then you have the appropriate amount. But that's usually something like 6 to 8 grams of antibiotic per batch of cement, or 6 to 8 units of antibiotics per batch of cement. And then lastly, you want to make it easy to remove, so don't pressurize it. You want to minimize the amount that goes up the tibial intramedullary space or in the talar space. I usually dye my cement blue, and the reason is that when you come back for round 2, white cement and bone can sometimes be hard to differentiate, and so the blue one, at least you'll know it's not bone. And then, for the exact reason you don't have to remove any excess bone for the sake of your revision. So here's an example. This is a broken high foot nail. I didn't know if it was infected or not. That was referred to me. Here's after I've removed the broken portion. You can tell from that retractor up there, I'm kind of hating myself, so I'm going to have to make a cortical window to pound the rest of the nail out. I did, and then this is me debriding the inside of the canal, a long suction curette device. And I put a little tiny spacer in there. All the intraoperative sections were negative. However, I still didn't believe that it was totally not infected, so I put a little tiny spacer in there. I put on antibiotics. You can see how small that spacer is, and so I had a plan to possibly place a long nail-shaped intramedullary spacer in there. I ended up just doing a small one like this and making it easy for me to retrieve. Simply also because I didn't have to fill a defect where I was worried about the foot shortening up into the hole because he did have a fair amount of medial talus left. So I left some local antibiotic elution there, but nonetheless, it matched my clinical suspicion. On the other hand, here was a total ankle referred to me that had MRSA, so we knew everything needed to come out. So took the implants out, did a complete debridement, and then put a large spacer in that was going to fill the cavity. Similar to the other side, I didn't think that one was necessarily had as high of a risk, whereas on this one, we want it to be maximal space filling because we don't want the foot to shorten into the hole, and also I don't have to worry about cement going up or down where the intramedullary nail was. So just some examples, match your own needs. So, when it comes to revision, I think this is a topic for a different time, but after the infection's eradicated, it's the same as any other revision. You can go to a TTC, you go to a revision total ankle. Keep in mind the reconstruction ladder. A lot of this is going to depend on bone loss and the patient's desires. How much more morbidity do they want to take on? And I think the big question here too is what even has better outcomes between a TTC and a revision total ankle? There's been mixed results about that in the literature. So, in some ways, to do a revision to a TTC is actually a more morbid operation than it is to revise them to a total ankle. I think that's the only thing that I'm going to really bring up here. For this gentleman, I showed the spacer on before.
All right, guys, just in the interest of time and to keep our programming moving forward, I'm going to end this. I will make sure that when we upload this virtually later on, that Eddie's full talk is on there. But I wanted to thank you, Turner and Bonnie, for a great session on infections. It's something that is challenging to all of us, and you guys cover that well, so I appreciate it. Hope you guys can get some sleep now.
Thank you.
All right, everybody, we'll see you back in 2 minutes at the top of the hour.